Okay, well, welcome back to the second plenary, folks. And this one, again, I think is a nice follow-on from this morning, which is really driving into the nuts and bolts about improving the quality and responsiveness in primary health care. The reality is that in Canada, overall, the more we know about the healthcare system, the less we should be impressed by the quality that it delivers. There are safety problems, there are comprehensiveness problems, there's precious little outcomes data, and there is a real problem with some major populations, not just marginalized populations, but the frail and the frail elderly, and as we discussed this morning, people with particularly multiple chronic diseases. So we're very lucky to have a panel who will address these issues and really get down to the what do we need to do to improve the quality of care. And since this is a big part of the case that you might wish to make for community health center expansion, being able to deliver and demonstrate that you have delivered higher quality primary health care should be a major assist to the movement. So again, I'm going to introduce the panelists very briefly. To my far right, to your left, is Susan Shaw. Susan Shaw is the chair of the Saskatchewan Health Quality Council, and she's an anesthesiologist by day. And we occasionally drink beer together and swap books, although it's a one-way exchange. Typically, I send my books into the black hole of Susan's bedstand, never to emerge again. I'm not reminding you or anything. It is true, actually. And then next is Mayo Hawco, who is the Executive Director of the Bramalea Community Health Centre and also chairs Ontario Community Health Centres Network Clinical Services Advisory Group. To her right, to her left, and your again right, is Michael. You met Michael this morning. I assume your memories are still decent, so I'm not introducing him again. And then to my immediate right is Barbara Wiktorowicz, who is the Executive Director of the Canadian Centre for Accreditation, an organization that can potentially have a great deal to do with quality improvement in Canada. So like this morning, only in some ways unlike this morning, we are going to start off with 1 to 2 minutes. 1 to 2 minutes means 1 to 2 minutes in Greenwich time, or however you wish to do it, by the Gregorian calendar or whatever. We want this to go pretty quickly at the beginning because it's right after lunch. People are postprandial. The lighting is such that unless you're staring into them, you kind of want to nap anyway. So don't assist that impulse. You will get to say what you want to say later on. You know, you don't. It's unlikely in your opening 2 minutes that you will get to say every conceivable thought you've ever had about this subject. So don't try it. And Rachlis, don't speed up to do it. And then we will get into an exchange, because this is it's a complicated but very interesting and important topic. So believe me, you will have your time, and we have almost 90 minutes. And then, of course, you folks in the audience, again, the quicker you can relieve me of having to keep the conversation going with my peculiar questions, the better off you'll be and the better served you'll be. So without further ado, I'm going to start. Might as well start with the same rough order. So I'm going to ask Susan to give an intro, and then we'll just move down the line. So I think that, go ahead.
I'm not sure if this is a live mic yet, though. Is it?
Is it? Is the mic on?
It is on? A little closer.
There
okay.
we go.
I am Susan Shaw, and like Stephen said, I practice medicine as an anesthesiologist, but I primarily practice as an intensive care doctor. So you may be wondering why I'm here. I was wondering that myself. I see, if I'm seeing a patient, it's absolutely the failure of preventative primary care. So my end of the patient journey is the very tail end often. So you may be wondering why I'm here, but why I'm here is because I have a lot of personal experience within my practice, but also within the work I do outside of my clinical work, which is with Health Quality Council and also with priority setting with the provincial healthcare system. I've seen the power of measurement, and I'm a strong believer in it, both in my clinical practice and, like I said, I believe, though, when you look at measurement, it needs to be timely, needs to be credible, it needs to be, most importantly, meaningful to patients and to providers, with common definitions and infrastructure, whether that's on collection, reporting, or analysis, which is not administrative data, which is what we make most of our decisions off of. So I'm a believer of we're not lacking for data, we're lacking meaningful, useful data. And that's one thing that both Stephen and I are struggling to help create across the province. Saskatchewan is, though, using a new way of working together. We like to call it thinking and acting as one, where we've got agreement across the province on what are our primary outcomes that we're trying to achieve for our patients and our public. How are we going to get there, and how are we going to know that we got there? And that's through the measurement side. And I will be honest, we're struggling on that side of things, but we are, I think, making good progress on there. We do have targets on primary care, and we do have some very exciting work going on in the province through 8 innovation sites, which to me very much are looking at mimicking some of, if not all of, the strengths of the community health center model. And maybe we can talk a bit more of that as we go through our conversation. But that's really what I wanted to say about who I am, why I'm here, and why I believe passionately about the importance of measurement.
Well done. Okay. Inspirationally brief. It was great.
I'll see if I can keep to that standard. Hi, my name is Mayo Hawco, and I work with the Bramalea Community Health Center. Just a few quick facts about Bramalea Community Health Center. We've only been operational for 4 years. I've been there for 5 years. About 50% of the people that live in our catchment area are immigrants. And the first 18 months of service, we were seeing approximately 60% of our panel was non-insured. With a new CHC, it comes with, I think, many sort of unique challenges and unique opportunities. One of the unique opportunities is the fact that we had a blank slate. So we had the opportunity to sort of view the world differently and explore different ways of doing things. One of the things that we were most mindful of as we engaged in processes was to ensure that as we were introducing things that were new tools, new language, new ways of being in our community, is that we stayed true to the values and the philosophy and the cornerstones of which our model of care was built. So it's been an interesting journey. We too believe in measurement. And again, as a new center, we were fortunate because when we did baseline data, everything was 0. So really we can only go up.
That's good.
Well said. I think that what I'd like to, just a few things off the top of my head that I sort of didn't get to before, and I knew there would be this panel, I do, you know, people have heard give to Caesar what is Caesar's, right? And so this is on the point that I'm a massively strong believer in working with communities, and I think what Regent Park and others have done with Pathways to Education is amazing. And in fact, what South Riverdale Community Health Center did in the 80s around lead pollution, which affected not just that neighborhood, but the whole country, because we had impact on a national commission looking at lead in the environment at that point. However, you're not going to get credit for any of that stuff if you're seen as not being accessible and if you're seen as not having efficient, patient-friendly care. And so I certainly applaud Ontario CHCs for what they've been doing in a real soul-searching exercise to look at, you know, if you've got a doctor who's only got 200 or 300 patients, or an NP with only 200 or 300 patients, are those massively complex patients, or is this a doctor who's working just the way they would have worked on fee-for-service, except they're only seeing a half as many patients? And is it the same model of care that they're using? So that's one point. And then the other point I'm going to make, which is a real direct challenge, I think, to almost everyone in this room, is that high-performing health systems, whether it's Kaiser Permanente, Group Health Cooperative Puget Sound, VA, what they're looking at more than just primary health care. And I do not like it when I go to a place or talk to people in a health center, and I say, well, what's your team set up? Oh, we're all a team. There's 47 of us here. I think one of the issues we need to deal with is what is a core team, and whether it's group health, and they have to do it on the basis of the personnel they had, and that's always going to dictate things. But they have 2 family physicians, 1 MP, 2 RNs, 4 medical office assistants who are supposed to be responsible for 4,500 patients. And that isn't that they just then don't, if they don't see their patients, another team looks after them. So that's a challenge to you folks, because NPs don't like to work with doctors. And doctors, in general, don't want to work with NPs. They don't know what they do. So if you allow them, they will go into parallel play. And I think that this has got serious implications for the quality of care you deliver, its patient friendliness, and its efficiency, because you can't maintain as high a panel size, I think, when you've got this parallel play going on.
Okay. I just want to give you a little background on the Canadian Centre for Accreditation. It was originally called Community Organizational Health and was set up by Ontario CHCs to really be more responsive to the CHC model, and a model of accreditation that was more responsive to those characteristics. We recently grew by forming partnerships with other community service accreditation programs. So now we accredit community-based mental health and addiction, community sports services, family services, children and youth mental health. I guess the key message is that I think that based on emerging research and on feedback that we get on when we do evaluations with accredited organizations, is that accreditation can be a real key driver, an important element at a center for creating an environment, a quality improvement culture, an environment that pushes everyone to ask questions and to do better. There's some emerging research about accreditation being linked to client outcomes, and I know that's still really limited. But I think you need to have it by itself. Accreditation will not create that environment. You need the leadership and broader commitment. But an accreditation commitment to accreditation helps to create some timelines, a structure, some goals, some leading practices that are in the accreditation standards that the organization can work around and work towards. In the end, there's external recognition that you don't get often in other ways. And there's really a statement about accountability. You're willing to be transparent to the third party and to sort of show how you work. So those are, I think, all important in creating that kind of culture. And I think the accreditation bodies generally, and certainly the CCA has, go through a cycle of reviewing our standards so that they are reflecting emerging practices and emerging sort of best practices. So the model, the standards that we recently released integrate things that we've been talking about today. So around focus on health disparities and planning at a community level around addressing those, about your governance role in quality oversight and creating a more specific quality improvement plans at the organization. Emphasis on also kind of taking a proactive approach around client safety. So those are all things that I think the CHCs probably need to pay more attention to, and that's built into our new standards now. And we've always had standards around responsiveness to the community, which is one of our themes today, and around accessibility, because it was an accreditation standards that were built by community health centers.
Great, thank you. Okay. So let's start probing some of these issues, and maybe I'll start with you, Mayo, since you run a community health center. So what keeps you up at night on the quality side? Where do you think you have the biggest gaps, and what would you like to address as the highest priority?
I think we have many, many gaps. It's kind of hard to pick one, but I think, some of our challenges working in a diverse community. So for example, in my community, there's over 70 different languages spoken. So when you're talking about being accessible and being responsive and being inclusive, that does extend into primary care. How do you sort of design your services to meet all those diverse needs? There's often competing needs. Like often we will talk about, if we're doing something, we could pit staff needs against client needs. But often what we find is how do you, when you're being inclusive to one group, being exclusive to another group?
Great. And Susan, you wearing multiple hats in the system. You're a practitioner, you're leading the Health Quality Council, and you've got a glimpse of policy at the highest level with the provincial leadership team. So as you look at the landscape here, and the HQC has been going for 10 years now, how much progress do you see? What do we need to do to make a quantum leap forward in quality as opposed to the incremental, voluntary, we're happy when it happens, but we're not sure what to do when it doesn't?
Well, that's not an easy question. So I think
Would you like another one?
I would like. There were several in there, I think. I think the first thing was how far have we come in the 10 years? And I think I can only speak to the Saskatchewan experience, but we've come incredibly far in that we now have everybody at the table talking about the need to improve quality, with a general acceptance by most, if not all, that the quality of what we're doing so far is not adequate, that we're actually failing on many of our targets, hopes, and dreams. And I think that's because we've been working as a system, I should say we've not been working as a system, is how we've been working as a system. And that's what excites me actually about where we've come to locally in our province. If I also look about what's happened over the last 10 years is that we've really looked at making sure that we truly are patient first. And we're not there yet, but we're having conversations and I'm seeing behaviors that show me that we are working differently. We have patients in the room on most of our planning activities, most of our discussions, we even have provincial committees being chaired by patients, which I think is very exciting, which to me means we're actually starting to focus on what we mean by being patient-centered. We all thought that we were, but we turned out we were actually provider-centered and thinking we were patient-centered. So those are the things that excite me about where we've gone. I think that was the first question. I think your next question was, why have we not gone further, or what's going to be the next
what do we
big
need to
leap?
do next? I mean, I guess the context. So we've got all these things in place. We have lots of goodwill, but you know, when you look at even in Saskatchewan, you look at the data, we're kind of plateauing, right?
I agree. I think that we're at a critical growth point where we're kind of realizing that the next step is to have really difficult conversations and face the truth of how are incentives aligned, what are we willing to tolerate versus what do we want to accept. And that is going to be tough because that's tough politically. It's tough on a community level because we have many small communities who think what they want is what they've always had, a small hospital with a physician in a very traditional model. However, we know in our hearts that's not what's actually they need, but how do you get them to understand that without telling them what it is they need, which is a difficult thing to do. Plus, you've got the political landscape of locally a provincial party that's very popular in the rural setting. So that I think is, so I think we're at a point where to really get to the next step, we have to be willing to look at being brave enough to have difficult conversations and put elephants actually on the table and attack them. And that's what I think we need. I think we're doing well in actually having common definitions and an infrastructure that allows quality improvement to not be pockets, but to be replicated and shared. And I'm confident that that will take a few more years. That's like we're 2 years into a 20-year plan on that. But I'm confident that's going in the right direction. I'm nervous about the willingness to tackle those politically difficult. And it's going to be difficult for healthcare practitioners, it's going to be difficult for politicians, it's going to be difficult for CEOs. It's difficult on many levels. I'm not just saying it's all about how do doctors get paid. I think it's much, much bigger than that.
Great, thanks. So Barbara, you know, there's been a lot of, I think it's fair to say there are enhanced expectations of accreditors these days. That, you know, instead of being, yeah, everybody passes and we'll maybe grade you a little bit and maybe we'll slap you around a bit once in a while and say fix that in a year, and everybody does and it's all happy. What are you going to have to do in the accreditation area to turn up the heat on this pace of improvement? Because, you know, in the international context, Canada sucks.
Big time.
Big time. You know, on value for money, accessibility, all the measures. When you see the Commonwealth Fund surveys, the only country we ever beat some of the time is the United States, and that ain't no triumph. So you're sitting here, you know the state of the data, you know the state of the world, you know it's a conservative culture. Where do you think you need to push harder in order to accelerate improvement?
Well, first of all, I think some of that data is broader than community health centers, right? So
for sure.
Actually,
For sure.
the community health centers are probably, you know, doing better than the general curve.
Well, you should say
in terms
that,
of
yeah.
responsiveness.
You guys
and
should say
sort of
that
yeah,
nationally,
yeah.
right?
Somebody has to defend it. But anyway, so I'm not, you know, I don't think accreditation takes the credit for that. I think it's the commitment of the people in the sector that are working to be more responsive. You know, accreditation is not a magic bullet that, you know, by itself, it is going to change things. But I think it's that continual push to be responsive to your community, to notch up, you know, your work, to always be thinking, how can we increase the quality of our work? So it provides mechanisms for people in an organization to push each other and to do better. In the end, like the push from funders and that is going to probably create the change in structures and that. I don't know that accreditation is. I don't think accreditation can revolutionize things that way. I think that's a tougher political fight. I think it can support some of that by saying, here's, you know, this is some of the direction you need to go and show us that you're doing that. And I don't think it's terrible that most organizations eventually do get accredited. I think that's the whole point. And so there should be, I mean, what we create is opportunities to keep working at and meeting the standards. And that, I think that's really the goal, is not to blacklist people or organizations, but to say, you know, keep striving to meet some of the standards that are there.
And Michael, as you know, when we talk about comprehensive, effective primary health care with often complex patients, it's a tough thing to get a handle on quality-wise, right? So what we tend to do when we start building indicators and data sets is we pick the low-hanging fruit. Like, you know, do you do PAP tests at the right interval, and you know, the easy to count things, the easy to measure things with short term. We heard this morning in some ways, I think the beginning of the conversation is, we don't really have a handle on the tough stuff, and it's really hard to measure that. So if that's where CHCs really live and die in terms of their unique value add, what do you think the prospects are for developing information systems that can actually give us some insight as to whether they're doing a better job?
Well, I think this morning there was mention about the public health involvement, and I'm going to block on the name now, but in the United States, there is that fellow in New York City who's been studying so-called hotspots. And so, sorry, when my mind starts working, I'll give you his name, and happy to give reference to people if they're not familiar with it. But really, it's perfect for CHCs. It's population-based. It's usually place-based, and you start to map where the like in Ontario, we're talking about the 1% using 40%, or the 5% that are using 60, 70%. Right. One of the problems with that, parenthetically, is that they're different most years. So the people who use a lot of health care this year are the people who are just diagnosed with cancer or heart disease or other complex problems. Next year, they're more likely to revert to the mean a bit. But still, if you start mapping these, you'll start finding that there's a lot more of these folks in particular geographical areas, and it may be that it represents, let's say, a food desert. It may turn out that it represents a primary healthcare desert, or other things. So I think that to go beyond what we're thinking now, we need to start looking at some public health and population health approaches. I just want to throw out quickly to the people here who aren't from Saskatchewan, which I think is the majority, that although, of course, you folks are modest enough to say that you're far from perfect, which you are, but still, there's no other province, I think, within 2 orders of magnitude in terms of actual management of the health system. There's no other province where you can find the data at the provincial level by region on a whole range of indicators. Yes, they are plateauing. That should be a concern. You can't find that in other places. Ontario's data is much harder to find. And the other thing is that Saskatchewan has, compared to other provinces, an open, transparent culture where the deputy is in front of his wall with his indicators on a monthly basis, well, weekly with his team, but monthly with the CEOs of the regional health authorities, and it's all quite open. And finally, the point about patients, there's no other provinces, even BC, which has got some good stuff, but it's not as well organized. In Saskatchewan, there are at least 800 or so activated patients. At the health summit I was pleased to attend in April, there were 70 patients who were there. That this province has really adopted Don Berwick's mantra, nothing about me without me. And I think that should be a challenge to community health centers, because when you're talking, do you start talking about how your teams work? Do you just let the doctors and the NPs figure out what they want to do? Do you bring in patients for those conversations? How many processes in your health center don't have patients part of them? The Saskatchewan Department of Health has patients almost everywhere except at executive committee, and they were talking about putting them there too.
Great. So, Mary, again, you run a health center, and we hear about there's extrinsic motivation for getting better, which is you have accreditation, you have the government saying you have to produce this, you have these contracts, but then there's intrinsic motivation. You have people, staff, teams, providers who are really internally motivated to get on the quality improvement boat. Do you see this in action? I mean, how do you know whether the people who deliver the care are data seekers, they actually sort of keep up on the literature, they're interested in clinical pathways, they're interested in performance measurement, they don't fear data, they embrace data as essential? Where do you think, I mean, I'll ask you for your own experience, but in general, where do you think the culture is?
Well, I can only answer for my CHC where I work, so I will confine my answer to that. But I think it's fair to say in my CHC, and probably in some others as well, that the people who work there, they're there because they want to be there. They're driven by passion. They want to do good work. They're committed to the community. I think for the most part, they're open in their thinking. And if they're not, you can open them in their thinking. I don't know that the average healthcare provider that came to work in our center came wanting to embrace data, wanting to sort of look at numbers and look at that business side of things. When we talked about getting a data analyst, everyone's like, well, why do we need a data analyst? But I think really they want to do good. And as a leader, as the executive director, it's sort of, are they following best practice standards? Are they, following appropriate care, path careways? I think I have a role to play in that. And I have to be able to enable open conversation, bring knowledge into the center, set people up with coaches and mentors. So as a new CHC, we were quite young, but we're fortunate in the province of Ontario that CHCs were a movement. So people that came to work for us could go shadow their colleagues in other CHCs, and I think that's really been kind of helpful.
So just before you go on that, so how do you do that? I mean, I think that's getting into what Susan's saying. You got to have some sometimes difficult conversations, right? If
Sure.
people aren't, as you say, people don't go into this to provide care, and their first instinct is, and I'm going to be a healthcare provider because I love data. But on the other hand, we know that if you don't have data and you don't, you can't, you may believe you're doing the best thing, but you may not be, right? It's not that it's trickier than that. So, as you say, you have a role as the executive director.
Yes.
How's it gone so far? Like, and I'm asking because it's like, have you found successful ways to have those conversations where people, as you say, open their minds up a bit to it and come around to a position they may not have originally?
Well, there's no quick or easy answers to that. We try things. Sometimes they work, sometimes they don't. The things that don't work, we try not to, throw the baby out with the bathwater, so to speak. We try to learn from it and move forward. And it's, I guess sometimes it's a little bit of a tension. I think engaging, clients, we use the term client, not patients, engaging clients is really helpful. I think providers will certainly hear a client perspective far ahead of me telling them what I think the client perspective is. So I think creating those dialogues is good. At our center, for example, annual client survey, we sort of think that's kind of old school, and actually we were going to throw it out till our funder told us we had to do it. But we do mini surveys every week anytime we implement a new process. So we made changes to our intake process. So the first 5 intakes, the client goes through the process, then we have someone else come in and talk to them about what that process felt. So it's there, it's in real time, and the person that actually does the interviewing takes the information back and gives it directly to the provider who they saw, because we know who that particular client saw. as opposed to getting, client feed, get client surveys as aggregate data. So you're saying this is the big voice, and you're not really sure. No one's listening because everyone, well, that's not me. That's not my patients. That's not my clients. That's Dr. So-and-so or nurse so-and-so, right? So I think you really have to work hard to make those connections.
Great. So Susan, let's talk about information and specifically the evolution of the electronic health record, electronic medical record. As you know, Canada is not advanced in this area. How essential is it, do you think, to quality improvement? How much can we get done without it and without using it well and harvesting the data and analyzing it? In the parts of it that have been implemented, what have you and your colleagues found to be the most useful?
I never use electronic health record. So that'll be my first disclaimer, because our acute care hospitals in Saskatchewan do not have the infrastructure yet for it to be across the full patient journey. So pieces of what I see, labs, diagnostics, and dictated notes, I can access, but that's not truly electronic health record. It's a repository of information on a computer. We have seen a transition in our province to most providers using electronic health records, and I think there's been a great hope that that would be one of the missing pieces, but I think we have to remember they weren't built as quality improvement tools, and the vendors aren't really that interested in them becoming quality improvement tools. So we're having to do a lot of work to actually translate what we have to what we actually need, which is true. It's just the same thing. We keep repeating that over and over, I think, in how we do things. I don't think they're absolutely essential, though. I've seen many, if you look at the mecca of quality improvement based on data, which I think is Intermountain Health, they do it on paper. They start with paper, they build what they need on paper before they translate it and embed it into the patient record. And when I've been lucky enough to go to the NHS and see some amazing team-based quality improvement driven into patient care outcomes improving, which I think is the key last part, that started on paper. And then eventually, 5 years later, it turned into something that was electronic. So I don't think it's an absolute necessity. I know that it's not. I know it's a very expensive way to start off because you don't know what you need until you've created it. And I know that what we have in our province isn't quite right yet in terms of actually giving us the data we need. So again, it's not a lack of data, it's a lack of meaningful, useful data. And I just want to push you, Stephen.
I'm not on the panel.
You seem to think that we may not be interested in data, but I think physicians and providers are incredibly data-driven organisms. We're basically little mini scientists always doing our own personal little experiment about whether something worked. Now that's not the quality improvement we want, but we are very interested as providers, I think that's where you're relating. People are very curious about what care are we providing and how is it making an impact. And the struggle is that you can't tell me. I don't know how good I am at what I do. So I assume I'm great, but you can't tell me anything different because the data we have doesn't tell us that. And I think that's our challenge is how, and you know this to be true, the challenge for us is how do we create that so that we actually feed the curiosity of our providers. And it should be based on patient outcomes, not on just the volume of what we did last week or last year.
Well, I mean, I'm not going to debate with you, but I think your vision of the constant mini-experimenting clinician who creates his own or her own little database and responds to it and is genuinely curious about whether the practice is the best is less than a majority, in my estimation, but it's okay. We don't have to agree. We like diversity. So, Barbara,
show me the data.
I was going to say same thing. Same thing. So, Barbara, I'm asking you who's right. I'm asking you. So, again, when we think about what we need to do to get better on a larger scale, there is. Let's continue with the information theme. Again, knowing that most high-performing systems will all tell you that they can't do it without fabulous data well used. We don't have fabulous data well used in most places in Canadian healthcare. At what point does accreditation say, like, give everybody notice? and say, you know, it's irresponsible to say to the public, this is a good facility when it doesn't have the intelligence system required to know whether it's doing a good job or not. So how aggressive is accreditation prepared to be on this, do you think? I mean, I'm not asking you to answer for the whole industry, and we're only going to quote you in the paper, so you might as well speak candidly here.
Yeah. I mean, I think it's a very good question, Stephen. I don't know if this is, oh, there it is. Yeah, I think it's a very good question. I don't know. I think you're giving accreditation, more power than it
I want it to have more
probably
power.
has
Yeah.
in terms of being able to move the movers and shakers. I mean, accreditation still is one way that an organization can kind of show, you know, we've got systems in place that in the end should lead to better client care. But I think accreditation is in the same boat as others, that like there isn't, how do we measure that, you know? And I'm not sure that we're in a position to say that we know how it's measured. I think it's a very complex question that everybody in the CHC struggles with, is what is good quality care and how do we get there? I mean, in the accreditation standards, we make certain assumptions. These are the pieces, this is the structure, this is the process, and you'll eventually get to good client outcomes. And I guess that's what we can say right now. There is more push in our standards, and I know in others, accreditation systems, to be collecting, to be attentive to information, to actually explicitly state these are the outcomes we want to achieve, and then do some measuring of whether we achieve them. So I think that, if nothing else, that at least pushes organizations to formulate them and to struggle with coming up with them, because it's not that easy to do that. So I think we're like along the road, but definitely not there.
Okay. Before I get to you, Michael, I would invite you to the microphones when you've got questions, and we'll turn it over to you in a minute. So Michael, again, you've seen a lot internationally, nationally. Supposing you had the magic wand, and you could say, here's the one thing I would do, either policy-wise or in some other way, to improve the quality and responsiveness of care faster than it is improving now, what would you do?
I'd say clinical governance for physicians. And what I mean by that is really what's been talked about back to Semmelweis and no doubt earlier, and thinking about Codman and his end result surgery stuff from 100+ years ago. He was saying, and he made a bad name for himself with other surgeons in Massachusetts by saying that his fellow surgeons weren't worth, they weren't worth their weight in bull excrement if they didn't see their patients once a year and follow them up and see whatever happened to them. And so, and again, that was all done with paper systems, but that's not enough. And I do agree that providers are curious. I was curious when I was a provider.
You're curious now, Michael.
And I'm kind of wondering whether I'm having any effect for the last 20 years. But but what I mean by clinical governance is whether you want to talk about the modern version or the 19th century version that Susan and me and my colleagues, we told you that there were dangerous people out there, and you needed to give us the monopoly on the delivery of this essential service, and then everything would be tickety-boo. And then it turns out that we didn't do that. We didn't establish standards. We didn't measure them. We didn't maintain them. So, for example, that with even in hospital settings, how many clinical departments are really measuring even, well, surgical infections I hope get measured everywhere. But I know a lot of places where they're not really followed up. The example I gave in my presentation was from 26 years ago, Kaiser Permanente, and in Britain, this clinical governance is now, it's mandated, it's public. And so that if you as a physician or any clinician are not, your performance is going to be measured, and then, yes, whole questions about, which we've been talking about, are we measuring what's easy as opposed to what's important? But your performance is going to be measured, and you're going to have to account for it on a regular basis. And as I said, at the Mayo Clinic and the Cleveland Clinic, that if your performance doesn't improve after you've been warned, just like everywhere else in society, you're going to be warned and then gone. So but I say that needs to be mandated, but I also can see that's something the profession has to grab, because you can't micromanage this. So the the culture in general amongst the Kaiser physicians, if you're part of the Permanente medical group, as it's called, then you've bought into all of that, and that the culture there is that you want to be measured, you want to continuously improve, and for sure, anybody who isn't performing well, you want them caught so they can be let go. And so I think it's a bit of a dance with society, and particularly physicians, but other clinicians as well, but particularly physicians, that where you want to incent the leadership that is there, and particularly these days, I think that there's more and more good leadership. You don't want it to get squashed by the doctors who don't want to be measured and just want to make a good living. You want to cultivate that leadership, and you want to have that leadership really take the issue and run with it. But at the same time, it's probably not going to happen the way you want it to happen without some sort of mandates from the top. So I don't know if what comes first, the chicken or the egg. I think you have to have curious providers, or else you got to have good clinicians, or else it's not going to work. And then you've got to support the leadership, because right now we are often pulling the carpet out from underneath the Susan Shaws and other people in this world who are trying to be leaders within the profession.
Thanks.
Yes. I just want to go back to a comment Michael made earlier this morning when he talked about George Washington dying because he was bled. And my comment is, bleeding was best practices in 1790. So, what necessarily is best practice isn't necessarily best medicine. I think what we've seen, though, is the evolution of a culture of data. And I grew up in a time when, I'll say the federal government specifically, used to actually do something. They usually have to have programs, they had people on the street, they actually did something. Now, all government does is count what we do. They don't do anything anymore. They regulate us, they count us. And when you talk about there's actually a book out, Whatever Happened to the Music Teacher, run by a professor in Moncton University, who, when he was a small kid in New Brunswick in a small town, he had a federal government office that had 2 employees, and for some reason the federal government subsidized a music teacher for the kids in the town. And 30 years later he went back, and they had about 100 government employees, and he asked what happened to the music teacher. They said, well, we couldn't afford to keep her. So, and all those 100 people are now measuring what other people are doing. So when we talk about the culture of data, I don't think it's that people are resistant to data. I think we're resistant to ridiculous data. I think we're resistant to, if anybody gets federal funding through CEIC, come on, you know what that's like. That is absolutely ridiculous. And personally, I would never make a management decision based on data. If a program wasn't working, I'd get out of my chair and look at it and sit and find out what's going on.
How would you know it wasn't working?
My gut feeling, 23 years of management. That's how I know.
That's it?
Yep, pretty much. I wouldn't rely on data because I know what data is. It's totally a manipulative thing. So I think we need to change the culture of data, quite frankly.
I know that Stephen is seething here, so
I'm not seething. I'm amused.
But I think that I understand what you're saying. Useless data is worse than useless. That I know that like CHCs in Ontario for many years were producing tons of data and then it would just get dumped. That it turns out that in most First Nations communities they have to fill in over 200 forms a year, with almost no administration in these small percentages. So I'm completely sympathetic to that. But that on the other hand, you've gone way too far. You've gone way too far because there are certain things we can measure and should be measured, and you're not going to pick up that one doctor's got a 4% infection rate and the other doctors have a 1% infection rate if you're just going by your gut feeling. So yes,
you might go by your gut symptoms.
but I think yes, absolutely. Reject bad data and almost the punishment of collecting data that is useless, that's not going to be used. But again, remember that Semmelweis was told by other obstetricians that were infecting their patients that his counting didn't matter. And so you don't want to be with those obstetricians who were infecting women. And that's, I'm afraid, I'm going to put that on you. If you say you reject all data, you're going to have to wear that, okay? So reject bad data, fine. But don't say you're rejecting all data.
Adriana.
I would
It was
like
supposed to be
go-
provocative.
Yeah, that's good. I would like to go to the question that's in your thing, 'cause I think this is what we're really dealing with, because I don't think anybody's saying we have to, and even Michael, in your responses, it's very focused still on, even when you take the Mayo, it's about the primary, it's about care and sickness and health and the role of a doctor and a physician. And I think the question says, how do we ensure that the emphasis on quality improvement in clinical services, which absolutely everybody gets and wants to make sure the obstetrician's not infecting me, does not come at the expense of critical health promotion and community development programs. We talked this morning about building healthy communities. I think the question I want to put back to you, I don't want to hear any more about the obstetricians and the infection rates and PAPs and mammograms. I think we will get that right, and we will figure out what the right thing is to measure for that. But no one is trying to figure out how to do health prevention and promotion. No one's trying to figure out the impact on whether you're doing community health and the impact on keeping people well. We took this morning with Mid-Maine. It's not because that doctor is going to do a good job that they can then be sent to another fee-for-service. It's because of the wraparound services. So I would like to see the next hour to focus on, or the rest of it, to talk about how do we begin, and who in this room is already trying to figure out the impact of people doing work on health promotion, health prevention, social determinants, keeping a healthy community. How are we knowing we're doing that well? We said that's the course of what we are different about CHCs, and yet when we talk about data, we always go back to PAPs and mammograms.
Okay, Adriana, applause. But Adriana, I could repeat what I said 10 minutes ago about mapping your hotspots, knowing which people in your community are really suffering. Why? Because then you can make a community diagnosis about place. And so that, and then you can. So do you want me to keep on repeating what I said a few minutes ago? So that's what I'm saying. That if the problem is that you've got a food desert, if that's the problem, or as we're just waking up to this in Canada and the United States, that the food companies are spending hundreds of millions a year giving us their latest French fry version and then sticking our heads in functional MRI scanners so that they can get their products to react in our brains the same way cocaine does. So that yes, we got to take on the food deserts. We've got to take on the municipal zoning. We've got to take on the Ontario Municipal Board that allows drive-throughs. We've got to take on a provincial government that would like to raise taxes in Ontario, but the goddamn NDP won't push them there. So yes, we've got to do a whole bunch of things at the community level. We've got to be measuring things like high school graduation rates, school readiness rates. We've got to be measuring all of those things, and we've got to be making them better. But as I said, and I can keep on going, except I didn't want to go on forever. Yeah. But when push comes to shove, if you can't take on new patients, and if you can't document what you're doing clinically, then all the rest of that stuff. So my model for community health care always was.
I challenge that, Michael.
Okay.
I don't think, I know, I've been in the sector for 25 years, and every time we say, what do we want to measure, it's always about medical and, nursing and all. It's a very important part, but it's one small part of what CHC is all about. And in Southeast Lynn, we did do a whole mapping. We did the social material deprivation. We lined it up, looked at the correlation to the health outcomes, disease modalities, and all of that. We know where they are. And of course, we can go and work on the neighborhoods. We can do a wraparound service. But the issue is not just taking care of the individual. And
I didn't say that it was.
Okay, because I think
I'm saying if you can't prove you're looking after individuals properly, you won't get to do the other stuff that's so important, more important.
The hotspotters, and I've looked at that material. Sure, it makes absolute sense. Do a wrap around that, and Drummond, as much as from an economist perspective, he said the same thing. Go and take care of the hotspotters, and you'll get the healthcare cost down. And understand that. But I think there are policy changes. There are municipalities. I think you've just mentioned some of those now. What kind of data are we going to be looking at? What data will support in saying that the work that we did in developing a water park for the children in a certain neighborhood actually is making a huge difference in how the kids are going to develop and do better? I think the problem is with the hotspotter and those kind of data, we are still dealing with when at a different, when it's too late. in some cases. So we need to shift the lens to an earlier time frame when we can actually make a difference, because by the time they're coming to you, Susan, it's gone. I mean, and you can just do a patching and system navigation and do a wraparound, but I'm not talking about care anymore. We're talking about changing the way where we live, work, and play. And of course, when we get sick, we should get good, high-quality services.
So Susan, you wanted to get in this discussion a little earlier.
I might take a
Are you
crack at it,
reconsidering?
because I'm very much at the wrong end of the type of work that you're doing when you look at my clinical work, but I can just speak a little bit to some of the work that we are doing, because as you know, healthcare is only 20% of health. The rest is social determinants of health. The challenge is 80%. We're already spending all that money. Yes, and until we get costs out of acute care, we won't have money to do the things we need to do. So that's one thing that I've had to philosophically wrangle with, because absolutely we're just going to keep doing more of the same. So what we're doing in Saskatchewan, I think is very exciting to me, is actually that intersectoral work, where we are starting to, so I can't quote you the numbers, I should know them by now, but Saskatoon Health Region identified who were their number one. They did some hot spotting. They found out who came through their emergency room the most, and they identified 23 people, I think, that now we have a plan through United Way, SHR, and Ministry of Social Services, not Health, to identify housing for those people, because that's the need that they have, and that should actually, we're spending $200,000 on that one person anyway, let's put it into a housing plan. So that's the type of work that can start to happen. It's not going to transform the entire province, but it's a start to try and get money out of where it shouldn't be spent to where it should be spent. We're seeing partnerships with education. Intermountain Health, number one thing they're trying to do to improve the health, actually the sustainability of the health care system, is to improve the graduation rate. So that's where there is a role and a responsibility of whether it be the intensive care doctor or the primary care doctor or the nurse practitioner or the social worker to actually be out there partnering and arguing strongly that this is where our dollars should be. And I think that's what I find very exciting about what we are doing in Saskatchewan, is we are working with education, social services, corrections and policing, parks and culture, recreation on obesity in children, and trying to do it that way, because now what measures should we do? That's a very different question, but we're trying to determine what those are. So that I agree with what you're saying, but you can't find new dollars until you stop spending dollars in the wrong place, and that's what I'm hoping we'll be able to achieve.
Great, thank you.
If I may chime in?
Sure.
I also think, that we're talking a lot about data, external data, but we, in our individual CHCs, we have some control over the data we collect. We have some control over the indicators that we set. In my CHC, all of our community teams have indicators that they have to reach. Anytime we run a health promotion group, there's an indicator. Anytime we do some work out in the community. And for us, some of that is we're just creating baseline data. We're trying to find out, where we can put our resources in the community. We go into schools. When we go into schools, we do sort of pre and post assessments, but we have indicators for those. So it's not a lot, but it's a step. And if we say that we're doing it, and if we can share it, I think we can learn from it.
And if you own it, you'll pay attention to it, right?
Yes, for sure.
Exactly.
Hi, I'm Cheryl Hewitt. I'm a member of the Saskatoon Clinic and of the Mid-Main Clinic in Vancouver. And I've worked for many years in a not-for-profit that is health promotion funded. We work with peer support groups and peer-led groups, and we help people learn the skills they need to work effectively in small groups. And it is a huge, and we're health promotion funded from Vancouver Coastal Health. It's a huge determinant of health, how connected you can be in your community. There's a couple of things I wanted to challenge everyone's thinking about. One is when we have data, unless it's attached to the stories like we heard this morning from Hirsch about the 92-year-old woman, it doesn't come to life for anybody in a decision-making role that thinks about it. So we are challenged when we're collecting data to attach the data to the stories of the people that we work with and how their lives are changed. So that's a challenge, a question I have to everyone who works in this. How do we collect the data and attach it to the stories? The second thing is we're part of an indicators project, a common indicators project for Vancouver Coastal Health for health promotion work. And we are trying to create common indicators to assess outcomes from health promotion. But what we found, because we work with groups and not individuals, is that the indicators and the outcomes relate to individuals, not groups. So we're being asked to ask the folks in our groups, did you make new friends when you came to our projects? Well, that's not what we're about. It's irrelevant to what we're doing. But in this grand scheme of common indicators, it seems to be focused on those of us who work with individual clients. And just as to take a leaf out of Michael's book, a little aside here, I can't stand the language, clients, patients. I guess I'm too co-op-y. I'm a member. I come in and I get healthcare as a right of citizenship, and we have to address the power dynamics that are inside that word patient. It's a challenge to everybody in the room. Anyhow, how do we move when we're doing accreditation and we're creating all this data? How do we move from shifting the questions about individuals into questions about groups and communities? Because we're not going to be able to address what some of the others raised about what the impact is on people's everyday lives. Because it's really not about health services at CHCs. It's about creating healthy communities. It's not about dealing with disease. It's about addressing health. And we measure the stuff related to disease through a medical lens. How do we shift it to a different kind of frame of thinking that actually matches what we're trying to do?
In terms of accreditation, what I mentioned earlier is that we have created standards in the new, the new standards that we've got that ask, do you look at what are the health disparities in your community? Do you have a strategy or a plan to address those? So it's, I mean, again, we're not giving people the answer. We're just saying, have you thought about these? Can you give us some examples? How have you got a plan in terms of how you're going to address those? The other aspect in terms of our standards is the health promotion has to be linked into all the work. So it's really expected that even if you're a primary care provider, you have a health promotion perspective. So that we've worded the standards that way as well. As well as if you have a health promotion person, staff, that they are part of the team and the work in how you're responding to your community. So that, I mean, that's our limited role in answering that question. Others want to jump in?
Come on, you got to take that on. Somebody.
Can I just give you my favorite data story? Back in 1992, I saw the results of our client list, and it said that we had a bunch of very, very old people, like it broke it down by groups, like 90 plus, many of our patients. And it did make sense to me, just from observation. So I went around to all the providers and I said, this says our clients are really old. And every one of them said, well, I don't really see it, but how can the data be wrong? And I said, yeah, how could the data be wrong? So I had to do something about all these very old people. So I got a grant from the federal government to work with these really old people. And after I got the money, I found out that the computer system, if you didn't put the year of birth in, it defaulted to 00, which meant everybody was born in 1900.
Yeah, well, who's defending that?
So now I had this wad of money for these old people, and I won't tell you what I did with it.
Yeah. Well, whatever. So, I mean, part of this discussion, I mean, it's been very wide-ranging, but it does raise the issues of whatever information you're going to have should be related to what you want to accomplish. And there seems to be quite a diversity of what people want to accomplish, all the way from the Rachlis thesis, which is your core job and your identity has to have something to do with healthcare, or no one's going to give you any money, and people have to get their healthcare somewhere, to, yeah, but it's a small part, essential part of what people need, and we need to, as Adriana put it, how do we know if this stuff is going to be effective, and the wraparound services? As you know, there is a big research enterprise that's been going on for decades trying to figure out what health promotion, whether it works or whether it doesn't. There have been huge multi-site, large-scale trials, and the jury's out on most of them, right? I mean, there's a few that are obviously successful, like Head Start, but otherwise, it's a pretty mixed bag out there. So it raises the issue, and people in the audience can get into this discussion too. We don't have to make the panel have to figure all this out. Who owns the information agenda, and who decides and who gets to say, look, this is what we're trying to do, this is what we need to measure it, this is the time frame, is really, really important. So as a movement, where should you be active here? What should be the CHC collective agenda in influencing the information agenda for two reasons? One, to measure what you think is important, but secondly, to relieve yourselves of being, or getting out from under the burden of being measured on things that you don't think are terribly important to your existence, but end up being part of your accountability framework.
Can I interrupt, Stephen, because I feel like I am just turned to straw here. The most important stuff you do is the improving the health of your community. Okay, I completely agree with that. Can we please not accuse me of not believing that? Can we have a truce on that? Yeah. All I'm saying is that you won't get a chance to do that unless you can measure and do the other stuff effectively. And I know there's a number of places across this country who are at risk because they are not accessible for the primary medical care or NP care that they're funded for. So that's all I'm saying. Give Caesar what Caesar's paying you for and shove it up his nose at how well you're doing it, that you are doing the traditional stuff that you are mainly paid for way better than everybody else. And that's what the Ontario CHCs have proved in general right now, and that's why, one of the main reasons why you're riding so high. And then you have the opportunity to do the stuff that I completely agree with you is the most important work. So that's what I'm saying. And in 1976, I said my attitude towards a community health center is we have a carrot and stick model. We've got the carrots of high quality primary health care to draw people in and give us a halo. And then we can give our clients, our community, our patients, our members, the sticks they need to go out and beat the rest of society to get the housing, the income, and the other social determinants of health they need. But you don't get to do that unless you can do the other stuff first. So just want to clarify that.
It's clear.
So I came up to speak before you said that, but I'm going to build on that.
Go ahead.
So, I mean, I don't want to be Pollyanna about data. I think when we talk about data, sometimes we forget about, like we get kind of too drilled down into almost a mechanistic mindset. For us at Access Alliance, you know, years ago, we made a commitment to being evidence-informed. And I think evidence-informed is it's something that's very, I mean, that commitment to being evidence-informed is something that, from my experience for many years in the nonprofit sector, is very unique to health. And that commitment supports a lot of excellence in all of our organizations. I mean, accreditation is one piece of it. You know, putting aside the fact that now funders are holding our accreditation status over our head, which is the problematic aspect, accreditation is a positive force from my perspective, but being evidence-informed is about what is the information that's available to us and how does that support our understanding best practices and healthy outcomes. In terms of data, like, I mean, community health centers, so what data? You said what data? What information? What evidence? Community health centers, because of our values and our expertise, are increasingly doing community-based research where we, in fact, and this is truly member-centered, people-centered, client engagement. It's about creation, co-creation of information that we own that then informs our thinking and our practice. And community-based research, and it's very interesting, I was just at a meeting on Monday with Bud Hall, who is a leading Canadian at UVic in terms of community-based research, and he was talking about, and it reminded me, community-based research is co-creation of data with those communities that we work with. It's about then public education as a result of that information, so co-creation of knowledge, then education, community development with that knowledge, but then the systemic change. And I think that's the whole package of community health centers. But it is about quality data. We have to have that. But let's not get stuck on the data piece of it. Let's reframe that into co-creation
let's do that public education. We need to tell our stories. I mean, today somebody said, again, and you know, we're the best kept secret. Like, we have to do a way better job of saying where we are so successful, and then that has got to drive that system change, which we've been talking about all day. This damn system continues to need changing, but we have to use that knowledge which we co-create with those communities that we're working with to do that educational work and to change the system. So, I mean, that, for me, like, I'm totally with, like, I'm a proponent of good information, co-create it with the communities we work with, and use that, and we have to, that's gotta be our rock, because, and you're right, like the stuff in Ontario that we're doing with the SAMI and everything, that's powerful, and it's compelling. We can use it not just externally, internally. I'm using that internally with our teams to get better buy-in to how do we strengthen and deepen and be even better. So, you know, Michael, I'm totally with you. And I'm remembering in Ontario, the Health Quality Council, the first report, I mean, so many of those examples that were identified through the Health Quality Council were not clinical examples. They were all of those community examples, and so many of us saw ourselves in there. So, and that's powerful. Like, that, we've used that very powerfully to be able to promote a lot of things that we do, pointing to ourselves and the work we do in the Provincial Health Quality Council, the report cards, the quality report cards in the province. Well, well, because SAMI is an indicator of complexity that was developed, and that now we're able to use that and take a look at how we're doing, using all of those clinical indicators, ER, utilize, well, you can explain it better than me, anyhow. But it's exactly what you're saying, give to Caesar what Caesar wants. I mean, we're proving that even on those medical, most medical of indicators, we are high performing, and that is super, super powerful.
Persuasive, exactly. Thank you. Over here.
I'm just going to build on what Axel said, because she said a whole bunch of what I wanted to say. So I work in Ontario as well, and we have a provincial initiative called the Performance Management Committee Initiative, and basically it harkens back to this conversation, reminds me of the conversations we've had around that table, which is what data, why data, for what, how do we actually create a language so that we can become part of a larger discourse. And some of the accusations that I've heard over time about community health centers is we're really, really good at talking to each other, but not so much about talking to other parts of the system. And this has allowed us to do exactly what Axel was saying in terms of having those discussions, taking some information that allows us to debate internally within our organizations and shift the mindset and the culture to not resist, but to find ways to actually tell our story. And I absolutely agree the narrative has to actually be combined with the data, because that's the whole story. I think that what we've done around complexity, and Axel mentioned it, but this is actually the purview of the work that Jen has done. Jennifer Rayner that spoke to us this morning, through our researcher Rick Glazer, whom most of us know about. And this has actually allowed us to, in fact, have an indicator of complexity, which is what we're trying to say. The reason that we see who we see, the reason that those numbers are what they are, the reason that we're seeing people, even when we take a pap smear, so the reason that we may have low numbers is because of the complexity of the individual that we're seeing. So how do we actually take the information but tell our own story? And so it's a tool. That's all it is. It's a tool. And the group that we have, this Performance Management Committee, is a provincial group. And our conversations are not about the information per se. It's about the how. How do we collect it? Why are we collecting it? What do we need? And we've actually created a framework for beginning to collect some of those community initiatives, and for some of the beginning to create some indicators through the use of the CIW to look at some things that have already been done and trying to figure out if those indicators can actually apply to the communities that we work with. So it's just a tool. It's a tool like accreditation is a tool. It's a marker. It's a line in the sand. It's we put our stake down and see how we can improve, how we can throw this one out because it's not helping us. And it's not just that we need to, it really generates conversation, which is kind of cool because that's what's happening here. We have different perspectives and then we can talk about it, and I think it's kind of great that people get pissed off because it really provokes conversation that needs to happen. And we have to keep talking. It's not the result. There is no end. It's a journey. So it just helps us to have those deeper conversations.
Thank you.
Yes, Brenda McNeil. I'm the executive director at a Midtown CHC in Toronto. I just want to build on my fellow Ontario colleagues will know all of this, but we are currently in Ontario rolling out a very complex information management strategy. It does include an electronic medical record, but there are much more components to this strategy. And certainly what we are going to get from this is a wealth of information, data coming out our ears. It's how we use it. And that's the work of Lynn's committee in the Performance Management Committee and the work of people like Jen Rayner. So we're getting there, we're putting this framework into place, but where we need to take that next huge quantum leap is using that information to make good decisions around community care, health outcomes, and so on. So we're headed in that direction. It is a very complex project. There are others in the room that have been involved in this, and we hope to have the whole province deployed. That's 75 community health centers and 10 Aboriginal health access centers by sometime in 2014. So we're headed in that direction. And again, it's a framework that's going to help other decision makers in the province of Ontario to use that information wisely.
Thank you. Yes.
Yeah, hi, I'm Gary Machin. I'm with the Association of Community Health Centers and involved in the rollout of pilot project with the Canadian Index of Wellbeing. And some of what I was thinking was stirred up by some of Russ's comments, and it goes back to an experience I had when I was working for the Ministry of Community and Social Services. And I made an effort to work in the department that was responsible for making the decisions around the allocation of funds. Because prior to that, what I had noticed was that the ministry, not only was it not funding the things it had just passed legislation to fund, which was the least intrusive form of care, they were actually taking money away from that and funding things counter to their legislation. And I actually published a paper called Inside the Belly of the Beast, but what it described was a process whereby I would see these wonderfully voluminous reports with all sorts of evidence-based thinking, making a case for certain interventions, which I saw the program and the heads of the ministry not even looking at. And then I would see multi-million-dollar contracts get signed as a direct result of a luncheon. And maybe something would get scribbled down on a napkin. And so I think what we have to be really cognizant of is power, what our source of power is. I think in a time of economic expansion, it makes all sorts of sense. I think rational planning models can work extremely well. But when you're in times of economic constraint, then politics becomes the medium of exchange. And so the question before us is, how do we build our political base? And as we talked, obviously we know what we're up against with organizations like the Medical Association. That's what I would refer to as the power of the experts, who obviously have a huge influence on what happens here. There's the power of the bureaucracy, which is the ministries, but there's this thing called the power of the people. And I think that's where our potential lies. And this lady that spoke just before me talked about how she didn't think she was, or she struggled with the language client and patient, and she was there as a citizen, as a member of her organization. And I think that's the challenge. It's how do we engage the people who use our services and get them involved politically so that they aren't, you know, a bunch of satisfied customers, but they're actually involved. And they're involved not just because, you know, to further the cause, but it is actually healthy to become involved. So I think that, you know, I would challenge us to it's not so much that there's too much, that we shouldn't be doing due diligence around information. I just think really the challenge is thinking out a political strategy. Thank you.
Thanks, Gary. That's actually a great segue for me. I'm Sheila Bradick at the Regent Park Community Health Centre in Toronto. I was struck, Stephen, actually by your question about who owns data or indicator, who owns the information discussion. And I think that's essential. That's core to this. And a couple of points. One is taking a lesson from the Aboriginal community in terms of it's a conversation about the research that's been done on Aboriginals is now being done by Aboriginals for the benefit of the Aboriginal community, right? And that sense of ownership and control and participation and accountability that they have insisted upon as a means of claiming and owning their own experience. And I think that that's, you know, as we're talking about a people-centered or community-centered healthcare system, I think that's a theme or an ethic that can exchange from there. And it goes to your point, Gary, about community engagement and how do we engage that community voice. So I think there's a real legitimacy to starting to articulate another view about what is meaningful information to be gathered and on what basis is that sense of meaningfulness or that definition achieved, right? So there's some information is meaningful to health planners, and there's other information that may be meaningful to the community. And on what basis do we value one part of information over the other? I had the privilege, and others here had the privilege of sitting in a conversation recently with a number of people from our communities in Toronto who were accessing health services, and had a dialogue with them about what were the challenges that they faced in accessing health services and what was the meaning of health to them. And it wasn't a conversation about that I get my pap smear on a regular basis. It was a conversation about having a sense of attachment to community, having access to housing, having a role to play in community, and that a belief that and an acknowledgement that my experience had value. And I think that if we were to engage those people in a further conversation about, so given that, what do you think is important to measure? It's not going to be the pap smears. It's going to be something else. And from their experience, they would be quite able, I think, to help explore and articulate what would be meaningful indicators to them. And I think as we go through that process, the dialogue necessarily has to evolve. And it's the continuous challenge that we have, I think, as we're working with populations that have historically been marginalized or excluded from the dialogue and access to health services. How then do we bring that voice into the discussion about indicators in as much as we bring that voice into a discussion about health service access, right? It's the same theme that we continue to challenge.
Great, thank you. So we've got about 10 minutes left, and I would like to just shift the conversation a little bit for the final words from the panel, which is, we've talked a ton about data and information and all that. There's another aspect of this that's really critical too, which is, how are people educated to work in the system in whatever capacity? And specifically, are you optimistic that the preparation, the health science education programs, the social sector education programs are changing fast enough towards teaching people how to get involved in quality improvement and having quality improvement as a lens in everything that they do? Not just medicine, but across the board. And like, for example, I'll start with you, Mayo. Do you find that the people who come to work in your center especially the newer ones? Are they fundamentally different? Do they embrace a quality improvement ethos more than maybe people of my generation?
I wouldn't say that they embrace it more. As I said earlier, I think that most people in our environment are there to, they really generally want to do good. But I think the younger professionals that are coming in are definitely more comfortable and familiar with technology. I think they're a little bit easier to have dialogues and conversations with. I think the issue of sort of power and authority, I think, has a different shift. And it's definitely easier to have conversations with them. I think you can, I know at my center I can be quite frank and open in sort of what we expect and how we expect people to contribute. Also at the front end, I think we're really, really clear about this is how we practice here. And it's not a group of individual practitioners practicing. It is the practice of the center. A bunch of people are involved in that. You have an opportunity to inform it. But it is a collective move, and it involves other people. So other providers, other players, other people in the community, and certainly the clients with whom we work.
Great. Susan, you're among your many other hats, you're a professor. So you're involved in the education system. Do you think, well, the medical curriculum obviously you're most familiar with, is it changing towards a quality orientation?
No, and not fast enough at the same time. So there are small pieces within curricula all across the country, but it's not embedded in a way that's actually going to get us the capacity that these students and future providers need to actually be successful. And I think there's a long way for that. They'll be successful, but whether the system will be successful is a long way to go. I spend most of my time with my learners actually talking way more about what you're talking about today and what we're trying to talk about than I do about how an anesthetic machine works or how a drug might work, because I think there are small opportunities where you can have influence. When I do go into the classroom, I think that they come in, the people who come into at least medical school, I do some teaching and nursing as well, are different than at least my generation, would be about 20 years ago that I entered. There's a different curiosity and understanding. There's a different understanding of what system is. I think our learners are a bit more mature and well-rounded in that. But then we do something to them by putting them through med school and a traditional model of healthcare that beats it out of them. And I watch them go from first-year learners to fourth-year learners, and then first-year residents to fifth- or sixth-year residents. And you just, ooh. And you get them up a bit, and then they go down again. And I think that's not their fault. That's our fault. We own that. And I think I like what you said about the accountability, bringing them in. That's what I am seeing different, and it speaks to what Michael's saying about clinical governance. The conversations about what the expectations are and how we're going to work around here are changing, and there is a significant number of people interested in working differently, and I do have hope. But we need our medical curricula, and I'm sure the other healthcare professional curricula, to shift and be ahead of the curve rather than the catch-up that we're seeing today.
Great, thank you. Barbara?
Myself, yeah, I don't know if I can comment on the education side, but I think just to build on what Mayo's saying, I think at the organization is a crucial, a place where people can learn, and the environment you create there, and the expectation that people are, other people are going to be looking at your files, your case files. There's going to be questions. We're going to do audits, and the environment you create, if it's not a punishing environment, but a learning environment, is really crucial, because that quality improvement doesn't happen by just saying this is perfect and everybody's got to do this. It's always asking questions and learning and supporting each other. So I think that's really important at an organizational level, and that's where like most people that in any profession are not the stars. They're just your average people that have some commitment and some level of skill. They need a lot of pushing and support, but with that support they can do better.
I think that typically education follows about 30 or 50 years behind everything else. That's my perception. The medical school education is still really slow on this. There's not so much. I will say a flag for you folks, if you're not aware of it. I think most of people in this room will know about the Institute for Healthcare Improvement, IHI. You may not know that IHI sponsors, I think it's like 600, 800 open school chapters throughout the world. Most are located in universities, but a number of them are in healthcare organizations like the Mayo Clinic and whatever. And there's a number of online training programs on basic quality improvement, et cetera, that are there. I think that within health professional training, that quality improvement is sort of where critical appraisal was in the 1980s. So in the 70s and early 80s, where it was just being heard about, it was like something for researchers. And then getting into the 90s was something that if you went into internal medicine or you're going to be a professor that you needed to know. And then pretty soon it was needed for everybody. And there still isn't enough training in critical appraisal, but I think quality improvement is sort of 30 years away from where it should be. And I think that one of the biggest problems, and so I will flag that IHI open schools, if you're not aware of them, there's probably one nearby, and you can tap into them. And the students involved, I know University of Toronto, there's like 600 students. It's student run, it's just one of the best things on campus, and it's the best interdisciplinary thing on campus. And that's the other thing, that we're teaching people in silos still. That 20 plus years ago, Carol Kirsch and I said, blow up health professional education, and I won't go into all the details, but we basically said you shouldn't get into your specific area until you're really advanced. None of this stuff about you have to know who you are because before you can mix with others. You need to mix with others, and then you can figure out who you are within that larger group.
So I'm sorry, we're out of time. So you'll have to by and large, as we had expected, this would be a lively discussion. I just want to plant one idea before we thank the panel, which is on this education thing, it's a paradox that in most sectors, the academy is a real incubator of innovation. In the health sector, the academy is by and large an antidote to innovation. It's actually a break. And it's a real issue. And I mean, it's not that they're not reflective about it. It's not that it's ill will. So influencing the trajectory of that is really important, and being a venue for apprenticeship, co-op programs, and socialization of a different model is an opportunity for you collectively as a movement to move that along in both ways. So I would urge you to think about that. If you've got just a short one, then we'll take it. So
I appreciate that very much. Thank you, Stephen. I'm actually now wearing my hat as the Director of Primary Care Services at Centretown Community Health Centre. And I think that one of the issues that has been reflected back to me in terms of where this conversation has gone today is actually at the root cause of the allergic reaction that primary care providers have when we start talking about quality improvement. They don't like the term, and they confuse it with data and change that is imposed on them from outside the organization. It's either sector-wide or is organizational improvement quality indicators that are then passed down through the organization. And they're resentful of that. They are not the curious professionals who want to experiment and change. And yet they're doing quality improvement all the time. And so one recent small example of this was implementing a no-show policy for clients who persistently don't show up for their appointments. And the physician and provider group getting together and deciding that they wanted to produce a no-show exempt list. And this speaks to what we do outside of direct medical care. For those people for whom they recognized that implementing a no-show policy would be the very last straw to them falling through the big gaps in the system that are waiting for them. Now, they didn't call that quality improvement. They didn't see it as quality improvement. They didn't identify it as patient-centered care. They didn't, but that's what they were doing. And then when we asked them to come forward with an example of quality improvement, they just had a complete allergic reaction, said, we don't want to talk about that stuff. Leave us alone to get on with what is actually quality improvement. So I think there's a real problem if we think that quality improvement is around data and accreditation, and we don't actually bring it right back down to the level of what are we looking at on the ground on an everyday basis that means that we are changing things to make them better, to meet the needs of our clients. That's all.
Thank you, Jane. Well, again, we've had a fabulous and rapidly moving hour and a half. I really want to thank Susan, Mayo, Michael, and Barbara for bravely taking on these issues. And it's good.